Assalamu alaikum. I am Dr. Mahmud Tushar, lecturer from the Department of Pharmacology. Today, our topic of discussion is anti-tubercular drugs. First of all, anti-tubercular drugs. What are the? It can be classified into two lines: first lines drugs and second line drugs. First line drugs are isoniazid, rifampicin, ethambutol, pyrozinamide, rifabutine, and rifapentine. And the second line drugs are group A. It can be further subdivided into group A, group B, and group C. Group A, levofloxacin, bedaquiline, linezolid. Group B, clofazimine, cycloserine. Group C, ethambutol, dilamide, pyrazinamide, amikacin, ethionamide, and para-amino-salicylic acid. Now, isoniazid. Isoniazid, it is an tubericidal synthetic prodrug and enzyme inhibitor. It acts mainly on rapidly multiplying organisms. Isoniazid blocks the mycolic acid synthetase enzyme, which mycolic acid synthetase enzyme is essential for the synthesis of mycolic acid of the Mycobacterium tuberculosis. So there will be no synthesis of the mycolic acid and no cell wall will be synthesized. Now, mechanism action. In this slide there is an overall the diagram of the mechanism action. Now, what are the adverse effects of isoniazid? Isoniazid, it mainly causes hepatitis and it causes peripheral neuropathy, hypersensitivity reaction like rash, urticaria, SLE, CNS disturbance, convulsion, seizure, memory loss, insomnia, GIT upset, hematological abnormalities, and all these are the adverse effects of isoniazid. Now, advice. We will give advice the patient to take pyridoxine 10 mg per day to avoid the peripheral neuropathy. Now, rifampicin. Rifampicin, it is a broad spectrum tuberculosidal and enzyme inducers. Mechanism action, it mainly acts on both extracellular and intracellular organisms. It inhibits the DNA dependent RNA polymerase and it interferes RNA synthesis. So no protein synthesis of the bacteria. Now, adverse effect of rifampicin. Rifampicin mainly causes hepatitis, cholestatic jaundice, influenza-like syndrome, allergic reactions, GIT upset, and light chain proteinuria. Now, we will give advice. The when a patient taking rifampicin, his body fluids color may turn into orange, and the patient may got afraid. So we will assure the patient that orange discoloration occurs may in urine, tears, saliva, and sweat. Now, pyrozinamide. Pyrozinamide is a prodrug synthetic antibactericidal. It has shortened the duration of treatment. Now, it is active against the dormant bacilli. It is taken up by the macrophage and converted to pyrazinoic acid by intracellular enzyme pyrazinamidase. Now, it causes the acidic environment and sterilizing effects. Adverse effects of pyrazinamide are it causes hyperuricemia and hyperuricemia induced gouty arthritis, hepatotoxicity, GIT upset. Advice, we will give advice to baseline and periodic serum uric acid level monitor. Now, mechanism in this slide there is a overall diagram of the anti-tubercular drugs. Now, ethambutol. It is a synthetic prodrug and tuberostatic. It inhibits the mycobacterial arabinosyl transferase enzyme. It prevents the arabinoglycan formation, which is an essential component of the cell wall. Now, cell wall gets defective. Adverse effects are it causes the color blindness, retrobulbar neuritis, loss of visual acuity, and it is contraindicated to children below the 6 years. Advice, we will give the patient advice to baseline and periodic visual acuity test. Now, this diagram is overall the treatment of DOTS. Initiation phase, dose and duration. Initiation phase, the isoniazid, it is 300 mg per day, 3 to 5 mg per kg body weight. Duration is 2 months. Rifampicin 600 mg per day. Duration is 2 months. Pyrazinamide is 1.5 gram per day. Duration 2 months. Ethambutol 1 gram per day. Duration 2 months. Now continuation phase duration is 4 months. Continuation phase drug combination is isoniazid and rifampicin. Now drug resistance TBs. MDR TB, multi-drug resistance TB. It means resistance to at least isoniazid and rifampicin with or without resistance to other first-line anti-TB drugs. Now extended drug resistance tuberculosis is MDR TB with additional resistance to moxifloxacin or levofloxacin and to one of two other group A drugs such as bedaquiline and linezolid. Now anti-tubercular drug therapy in pregnancy. Principles of the treatment of TB in pregnancy are the same. Rifampicin may increase the metabolism of vitamin K, so prophylactic administration to the mother and the neonate is recommended. Vitamin K, it is per oral given 10 mg per day for the 15 days prior to the expected date of delivery. EDD for the mother, and injection vitamin K IM intramuscular is given 1 mg as a single dose at the day of the birth for the neonate. Now chemoprophylaxis. Chemoprophylaxis is indicated into the newborn baby of the mother suffering from the TB, children less than 6 years having TB positive, household contact with TB patient with additional diseases like diabetes mellitus, HIV and malignancy. Treatment is it is usually treated with isoniazid for 6 months. Now there are some drug interactions occurs during the use of the anti-TB drugs. If we use rifampicin along with oral contraceptive pill, there may be contraceptive failure as the rifampicin is an enzyme inducers. Now rifampicin and warfarin. If we use combination rifampicin with warfarin, there will be no anticoagulant effect because rifampicin acts as an enzyme inducers. Now isoniazid and tolbutamide. Isoniazid is an enzyme inhibitor, so there will be hypoglycemia. Isoniazid plus benzodiazepine, there is a decreased metabolism of the benzodiazepine. So that's all. Thank you for listening to this anti-tubercular drugs. Thank you.